Thank you very much. I hope you can hear me and can see the slides. If one of you will just confirm for me, please.
Yes, I can see it.
Okay. So I'm presenting some work in the area of global newborn health. And this is to understand the type of neonatal interventions that take place in either the special care unit or the neonatal intensive care unit, and also the relation to breastfeeding outcomes. We've done it in 2 hospitals in Ghana, an example of a low and middle income countries. And the idea is to facilitate optimization of newborn care so that the babies are looked after in the appropriate places. The background of this in low and middle income countries, and Ghana is an example, babies that are born inside the facilities, these are the inborn babies who need any type of monitoring. If they're perfectly normal deliveries and babies of very low risk, they are usually roomed in with the mothers in the postnatal wards. But when these babies receive what is known as essential newborn care, which is very basic. If the physician or the midwife decides that the babies require a little extra care above that, they are scared to keep the baby in the postnatal ward because they feel that this is an increased load on midwives in the postnatal wards, and their knowledge and skill gaps as midwives, they tend to focus more on the maternal care. And many of the physicians feel that they may not be able to provide appropriate care for the babies. So such babies get into either the neonatal special care unit or the intensive care unit. And the disadvantage is that they add a burden of work to the already overworked, understaffed units. And you're also promoting unnecessary separation of babies from the mothers. Unfortunately, similar findings are also nowadays being reported even in the high-income countries. Regarding the methodology, this was a retrospective study, and we chose it as a retrospective study because we didn't want any changes to take place in the interventions or the practices during the course of the study. We did it over a period of 1 year, and it was done in 2 hospitals. These were referral hospitals. One was the Greater Accra Regional Hospital, which I'll term as GHAR. This is a level 3 or NICU, which actually goes up to providing mechanical ventilation. The second hospital was the Tamale Teaching Hospital, which I'll abbreviate as TTH. This was a lower level, although it was a referral tertiary center. It had level 2 care or the special care newborn unit. And this goes up to only the continuous positive airway pressure and doesn't provide mechanical ventilation. The TTH hospital also has a special baby ward, which is linked with their pediatric ward. And the reason for having this is that when the newborns require this little additional care that I was mentioning, which we call as intermediary care or intermediate care, such babies can be roomed in with the mothers who, of course, don't require any special OB/GYN care, because in the pediatric ward, there will not be the obstetrician who can provide care for the mother. So if the mother is perfectly normal and is ready for discharge, babies who require that extra care can be kept with the mothers in the special baby ward. We got the Ghana Health Service Ethics Review Committee to approve this, and we were granted a waiver for informed consent. Regarding certain definitions which need to be clarified, when we say neonatal interventions, these are the ones that are either practiced in the special care unit or in the intensive care unit, a picture of which is shown here. These include extra thermal support in the form of a radiant warmer, an incubator. The babies here could receive oxygen, extra oxygen, respiratory support, either a nasal cannula, CPAP, mechanical ventilation. The mechanical ventilation, as I said, was only in the GHAR hospital. Babies could also receive nasogastric or orogastric feed, and the fluid support, which was either continuous IV fluids or parenteral nutrition if babies required longer fluid therapy. In addition, babies in the neonatal units could also receive blood transfusions or even have an exchange transfusion for severe jaundice. When we said no in NU interventions, these were babies who needed either extra observation or needed extra glucose monitoring, needed phototherapy, and we labeled it as, we wanted to find out babies that received only each one of these, that is either only glucose monitoring, only phototherapy, or only prophylactic IV antibiotics, which are sometimes given if you're suspecting infections in the newborn, or there are some predisposing factors such as prolonged rupture of membranes. And some of these babies also required some short-term, and a few will require more long-term IV fluids. There was also a subset of babies who did not receive any of these interventions, and we labeled these as no listed interventions. These were babies who really required just some extra observation, maybe a little extra monitoring of the respiratory rate, or observation for the type of feeding or inactivity. The limitations that we noted in this, which was a little unusual, in the Gar hospital, we found that all babies were tested for blood glucose levels, which doesn't happen in every unit. And because of this, it was difficult to document when the babies received only any other practice. In the TTH neonatal unit and the special baby ward, another unique thing which rather surprised us because we weren't aware of this type of practice, babies whose mothers could not supply breast milk or could not come to breastfeed their babies were not given formulas, which is rather unusual. They were administered intravenous fluids. It was reported to us that many of the mothers either could not afford formulas or were not willing to use the formulas. Here are some of the results of this study. First two columns, these are the types of interventions, the no neonatal unit interventions, no listed ones, or they had only like glucose monitoring, phototherapy, IV antibiotics, or IV fluids. I already told you the problem we had for the Gar hospital. We could note those who received only glucose monitoring, but because all of the babies got the glucose monitoring, we could not really make out the others who got only phototherapy, IV antibiotics, or IV fluids. But we have the data here as it is shown for the TTH neonatal unit. The third component was that neonatal special baby ward, where the babies were roomed in with the mothers. And here you can see a significant proportion of babies. These were babies who were now roomed in with the mothers and were in the improving stage. You can see here that a significant number of, although they are less than the total numbers, like in TTH, you have 983 total admissions, and GAR, we had 1995. But there is a significant minority which are receiving what we do not really call, as strictly speaking, the neonatal unit interventions, but are unnecessarily occupying space in the neonatal unit, and are also exposed, taking the work of the specialized nurses in this unit unnecessarily. Coming to the outcome for exclusive breastfeeding. The definition of this was that at the time of discharge, these babies were on total exclusive breastfeeding or were on express breast milk, which could be given with a cup or a spoon. And you can see here the highest rate of the breastfeeding, this 99.3, was with the TTH special baby ward where the babies were roomed in with the mothers. The next was in the TTH NU, and the lowest was in Garg. I can remind you here that TTH neonatal unit had this unusual practice of giving IV fluids and did not give formulas to the babies, which partly was responsible for the increased breastfeeding. So in summary, breastfeeding at discharge was highest in the TTH special baby ward and in the neonatal ward. And therefore, the avoidance of formulas by giving IV fluids did seem to play a major role. A similar finding has been reported by Rommelfanger and the unit, who also showed better breastfeeding rates in babies that had IV fluids postnatally. However, the value of using IV fluids to avoid formula feeds is not clear. And really, there can be potential problems because unnecessary IV fluids can also result. You have problems like local pain, swelling, and other problems such as infections, electrolyte disturbances. And such a procedure really needs more careful evaluation that is this justified or not. And it is a far better option that the babies get roomed in with the mother so that the mother can breastfeed or give express breast milk by cup or by spoon. So to summarize, the potential risks of unnecessary neonatal unit admissions in low and middle income countries. Number one, they increase the load on the already limited staff available. These are skilled nurses that have to look after this unit. And not only in this place, but we also had done an earlier study noted at the bottom of the slide of facility readiness in low and middle income countries, addressing these high risk or the small and sick newborns. And in some places, you may have one nurse who has to cater to 15 babies and even up to 30 babies. And most often the difficulty occurs in the night shift where there are far fewer nurses. Having these babies in the unit like this when they don't need to be there and they're better off staying with the mother also adds to overcrowding in these units. And it may result in more than one baby sharing a crib, an incubator, or being under the radiant warmer. Because of this, there is also increased potential risk of hospital-acquired infections, and we have unnecessary separation of babies from the mother. And also, they may get exposed to a totally unnecessary and less understood interventions, such as one of our units here giving unavoidable IV fluids to the babies just because the mother was not coming to breastfeed. So these are practices that we have to review very carefully and see if they're really justified. Now, when we look at these special groups of babies, as I said, that require just that extra or what we would label as low acuity care, that really doesn't require the neonatal intensive care or even the specialized care. And this type of care is often labeled as intermediate care, which is beyond a little higher than the basic essential newborn care, but it is less than what is required in the intensive care or the special care unit. There are two situations where such type of care is required. Number one, soon after birth, when some of these babies have some special high-risk factors. For example, if the mother has had prolonged rupture of membranes, we are concerned sometimes that the baby may develop infection, and these babies have to be observed, certain tests have to be done, and we have to wait for the reports. And in that transient period, we may have to give intravenous antibiotics. So this would be a little extra care beyond what is required or given in the postnatal wards. The second group of babies that require this type of care, and here again, we would like the mother or a mother figure to be there. And these are babies who have been either small or they've been sick in the special care unit or in the NICU, but who have now improved and are getting ready for discharge. Ideally, such babies in intermediary care should be managed with the mother, father, or mother surrogate under some supervision, This requires low acuity care and does not amount to special or neonatal intensive care. In the process of this type of intermediate care, and especially when the mother and babies are together, as I'm showing here in the photos in this, there are tremendous advantages. There is a task sharing because the mothers who are now supervised and have been given some counseling and training, they can do the non-specialized care for the babies, and this relieves the nurses who can then focus on the more specialized care. Mothers taking part in this type of care also helps to increase their confidence. It promotes earlier discharge, and we found in these studies there were fewer readmissions after the baby got discharged with the mother. We did not find an increase in the occurrence of infection, and ultimately we feel this should expand further into what is now called as family-centered or family-involved care. The other very important thing is that to be really sustainable, it can't be just done in the hospital alone. We need strengthening of the health system because it is necessary to have a proper infrastructure. That means, as shown in the photos earlier, we need a place so that mothers can stay with the babies. You need funds for that, for the mother-baby dyad, because we need to give food, beds for the mothers or reclining chairs, and bathroom facilities. In fact, in our study and earlier studies, very often in the low and middle income countries, families have to bring their own supply of food for the mothers, which should really not be done, especially when the mother is there to take care of the baby. In addition, because of the peculiar habits or practices which we have outlined, we feel that all neonatal units should periodically review their practices to ensure that there is focus on optimal type of care. So thank you very much for this. This article or the data that we've done here has just got published. It's open access, and I've written here the publication. It's in BMC Pediatrics. And those who want to have more details, it can be seen in this. Thank you very much for a patient hearing.